I'm here at 2018 ATP1A4 symposium. I'm Dr. Leigh Mack, and I'm on the board for Cure AHC, which is a US based but has international ties for alternating hemiplegia of childhood. And it was founded several years ago by a parent that has a child that has AHC and has since grown from just a organization supporting other parents and families with AHC to more of a sponsor in research in most recent terms. So I am the only board member that does not have a family member or child that has alternating hemiplegia of childhood. When I was approached for the board opening, I found it very interesting. It's very challenging from a genetic standpoint, from even a treatment standpoint, because it's neurological based. And even the variants and phenotypes are very challenging to isolate and identify. And from a clinical standpoint, it'd be challenging for any typical family physician to decisively just say this is AHC without doing a lot of work to arrive at that point. So, as part of the group to come up here, my intention was to network with other people from around the world and see what they're doing as far as new treatments, new plans for research, and also to learn about all the researchers that are currently directly or even indirectly related that are presenting here. And it's been quite interesting. A lot of this stuff is very upstream. With today's technology, I guess the biggest things we've been talking about behind the scenes are two different approaches, and there's two schools of thought. One is to keep going in the direction of a pharmaceutical solution. So the concept would be probably an encapsulation that go across the blood-brain barrier that has perhaps a targeting peptide and then has a small molecule treatment. So I was at a meeting about a year ago, and I was speaking with somebody from Max Planck, and she was doing research for Parkinson's in ATP1A2 and ATP1A3, and 1A3 is what we're here for. And interestingly enough, they're working on it. And I also met somebody from Arizona State, and it's based on, they're looking at the same gene we are, but for hearing loss. And so all these groups are kind of going their own direction. Obviously, Parkinson's a mainstream condition, and there's probably a lot more research money and a lot more people involved. So today I was asked if we were to do a pharmaceutical approach, how would you go about that? And I said, well, if I was going to do, if we were to go after it as a group, I would reach out to make a short list of the biotech companies that are doing research in gene therapy for Parkinson's, and then look further into see who is working specifically on the ATP1A3 and maybe novel approaches or treatment, small molecule treatment for that. And to that end, reach out to them as a group. So all of these foundations that are here would have to agree to approach these companies and say, this is our group, this is what our objectives are, where do they cross or where do they meet, and is it possible for this molecule to work on these variants that we have in ATP1A3? And if all that lined up, the strategy might be that we actually run studies in phase 1-2 trials in the patients with AHC. Just because from a strategic biotech standpoint, it's a lot less money than going straight to research in Parkinson's. So it may be a segue for them to step to success in a rare, and then take that and maybe hone it down a little bit and make it a little cleaner delivery and have a very more informed approach for their Parkinson's study and approval at that point. So I guess logically that would be the strategy I would use for a therapeutic drug approach. And the same thing holds true with the hearing loss. See what they're doing, see where everything's at on that. And I think us as a group with this condition have to almost team up and segue and see where we cross over to other conditions that have the same gene with the same variant or similar variant defects. And so the second part that's really interesting, that I've been and our group Cure HC has been working with, is actually using an AAV vector 9, which is a viral vector. So the virus is basically inert, for lack of a better term, as far as doing any damage to a patient or participant in a study. And Dr. Stephen Gray from Texas has worked on this before, and we're actually looking at talking. The strategy would be to replace the gene itself. And this has been historically done with some other conditions, and the AAV vector delivery system has been used, and toxicology studies have already been done in other areas as far as FDA is concerned. I think 10 to 15 years from now, we're going to see the genetic therapies and edits as much more commonplace. But I wouldn't discount the partnering for the small molecules and pharmaceuticals. Hopefully, I can add a little bit different perspective because I'm not a parent, so I kind of offer maybe an outside view, and also the experience with clinical research to offer some pathways and strategies so we can get to a real solution faster.